Endocrinology and diabetes and metabolism are E&M diseases, evaluation and management. Diabetes is primarily management. You know, the evaluation part is less so, whereas the other endocrine diseases are to a greater extent evaluation. That's especially true for internists, primary care doctors, since what you need to figure out is, does your patient have a complex endocrine case that you either want to work up partially or refer, or can you exclude what's going on here because it's really a common manifestation of something else and the patient really doesn't have the problem that you think they might have. So evaluation is a lot more of what I do than our diabetes colleagues like Dr. Villafuerte. So what I did is put together some various adrenal disorders and let's evaluate them together and learn a little bit perhaps that you might not already know. So 46-year-old woman with fatigue, weakness, irregular menses, and acne for 18 months was found to have osteopenia on a DEXA scan in the LS spine, and her PMH was unremarkable. She was 64 inches tall and weighed 130 pounds, and she had facial rubor, paroxysmal muscle weakness, hypertension, and muscle atrophy, and her urinary free cortisol excretion was at the high end of normal, and the baseline serum cortisol was at the high end of normal, but was 18 micrograms per deciliter, 17, the following morning after taking 1 milligram of dexamethasone at bedtime. And the plasma level of ACTH was 8 picograms per mil, with normals of 10 to 90. So the question that we would start out there, does this woman have Cushing syndrome? We think she might. And what might be the etiology? What organ is the pathology causing this Cushing syndrome? So take a second to think about it and take a show of hands, and then we'll take it from there. Okay, pituitary gland, pancreas, hypothalamus, adrenal cortex, and lung. Yeah, so that's right. Yeah, probably the adrenal cortex. The fact that the urinary free cortisol excretion is at the upper limit of normal is not at all atypical for people with adrenal adenomas. The fact that they failed to suppress with dexamethasone is a very important thing, telling you that there's no feedback regulation. Therefore, the ACTH level is really not contributing to the biology of the system. And although there are some limitations in the sensitivity and precision of our assays at low values, this one is reported arbitrarily here to be below normal, but sometimes the value will be 10 or 11, and it's really that the assay really is not sensitive or specific enough to tell you that it's really undetectable, not 8 or 10 picograms per mil. So that's sort of a laboratory issue, and nowadays the tests are much, much better than they were 10 years ago and 20 years ago. So this type of distinction is much more possible now than it was in years past. So patients who present with Cushing syndrome sometimes present like this. And of course none of us would miss this as Cushing syndrome, although many doctors did when I saw this man finally in evaluation. Of course he's got tremendous 3A and breast enlargement and facial rubor and central obesity with spindly extremities. You know, all of us would recognize this. Sadly, it didn't happen. But this lady also has Cushing syndrome. And here, really, you can only see that there's a little bit of facial redness. So you can see that she doesn't have a lot of hirsutism and doesn't have central obesity yet. So we would like to diagnose Cushing syndrome earlier rather than later, since there's a lot of morbidity in Cushing syndrome. So what are the things that should make you think about Cushing syndrome? There are a lot of things which you should think about, which are common. And things like poor libido, weight gain, red round face, irregular menses, body hair, high blood pressure, abnormal glucose values, all of those things, the majority of the people don't have Cushing syndrome. But when you see those things, you should have a fire lit up in your head. Don't forget Cushing syndrome. These things, the ecchymoses, proximal muscle weakness, And unexplained osteopenia in fractures, those things are relatively specific, much more so than some of the others. But many of these things, just keep them in the back of your mind and don't forget Cushing syndrome as a possibility. So when you have a patient with Cushing syndrome, you might have a candidate for Cushing syndrome. The first thing is to demonstrate the hypercortisolemia. Prove to yourself that the cortisol production is high. And then the next thing is it ACTH dependent or independent? Independent in our case. The next thing that we'll do is if there is ACTH secretion, where is it coming from? And then treat the patient. So there are basically two different ways to screen for Cushing syndrome, and there are advocates for both. I showed you in our first, well, I think most people use the overnight dexamethasone suppression test, since if there's Cushing syndrome, there's usually a impairment of the negative feedback regulation of ACTH secretion, and that is manifest by a failure of the plasma cortisol to fall to a low value. And that low value nowadays is defined by about 1.8 micrograms per deciliter, so that if you take a bunch of young healthy people like you guys, the vast majority of you will have a cortisol level below 1.8 the next morning. If you're an overweight person, there's a type of resistance to glucocorticoid negative feedback which occurs in obesity, which is not really understood very well. But overweight people tend to be less, to have more false positives, if you will. And the one where you get the most problems is when people are ill. Because when you're ill, you make more cortisol, your CRF rises, your ACTH rises, all of those things contribute to the failure of glucose negative feedback. And therefore, when you have people who are ill, that's not the time to figure out whether they have Cushing syndrome, unless the Cushing syndrome is really contributing to the morbidity and you see what's the matter with them. You say, hey, we got to figure out whether this is Cushing syndrome or not. But other than in that circumstance, which is a very difficult position to be in, what you want to do is cure their pneumonia and then send them home, let them feel better, and then work them up for Cushing syndrome. And the vast majority of people who have Cushing syndrome will fail the overnight dexamethasone suppression test. But not everyone. So that's why some people don't like it. So there are people with mild Cushing syndrome who will have plasma cortisol levels which are less than 2. So 6 out of about 81 here. So in this guy's series, maybe 8% of people failed. Well, this is a specialist in Cushing syndrome, and he gets all the cases that no one else got right. And therefore, I think that this is a little bit inflated, but the point's well taken, that if you really have a great suspicion that the patient has Cushing syndrome, but they suppress with dexamethasone, don't abandon your idea. So you want to give it at 11 p.m. and you want to measure it at 8 a.m. the next morning, and it effectively excludes Cushing syndrome. You don't get suppression, of course, in Cushing syndrome. If you have some GI problems and you have poor absorption, if you're taking a drug which accelerates the dexamethasone metabolism, Dilantin, barbiturates, the P450s, all of those things. When you have an illness, like I said before, a common one is alcoholism, chronic renal failure is in here, and all of those then will cause a type of pseudo-Cushing syndrome. And the one that I think I get to see the most is the fact that estrogens stimulate the production of cortisol binding globulin. Cortisol binding globulin binds to cortisol, and therefore it prolongs the metabolic clearance of cortisol so that the cortisol levels rise when you're taking estrogens, just like the total T4. No longer do we measure total T4 in our evaluation of thyroid disease because thyroid binding globulin is so confused the measurement of total T4 that now we do a free T4. But we don't measure a free cortisol in the blood. So every woman who's taking oral contraceptives has a high level of CBG and fails the overnight dexamethasone suppression test. Sort of pregnant ladies. So the next thing to do is to measure the urinary free cortisol. And in general, there's a pretty good correlation. The higher the urinary free cortisol, the higher the AM dexamethasone suppressed cortisol concentration. But you can see that it's really a very imperfect correlation. There are plenty of people who suppress a lot, but their urinary free cortisol is high. So when you have a suspicion that the patient has Cushing's and the overnight free cortisol fails, like a woman taking oral contraceptives, have her collect a 24-hour urine, and if they're normal down in here, then you can feel pretty comfortable, then that's the reason for her problem. So the distinction of these pseudo-Cushing states is not simple. So when you have someone who's sick, like I said before, they fail to suppress, the urinary free cortisol level is very similar, and here's the result with the low-dose dexamethasone suppression test. You can see that it can be very, very similar. So pseudo-Cushing's patients are very difficult to distinguish from true Cushing's patients. One of the things about Cushing syndrome is that there's a loss of the normal diurnal rhythm, so that in normal, young, healthy people, the plasma cortisol at midnight to 2 a.m. or so is generally 2-3 micrograms per deciliter, but in patients with Cushing syndrome, that diurnal rhythm is lost. Of course, it's not so easy to measure the plasma level of something at 2 or 3 a.m., where, as an outpatient, what are you going to have the patient do? Come to the hospital at 2 or 3 a.m.? It's not realistic to do that. So cortisol is present in saliva. So there is an approach to giving the patients this little tube where they salivate and freeze the sample and measure the cortisol in the sample. And it works pretty well, especially in research labs, but it doesn't work so well in practice. There are false positives and false negatives. And in my view, it doesn't really offer that much. So here is the nighttime salivary cortisol in Cushing syndrome patients, and you can see that it's higher than in the people who have unconfirmed Cushing syndrome or pseudo-Cushing's, normal volunteers. So it's different. But on the other hand, those people also have higher levels of urinary free cortisol, and they have a higher level of cortisol after the dexamethasone suppression test. So whereas this can be helpful, it's not exceedingly more helpful than any of the other tests that are available. Okay, the next thing to do is distinguish ACTH dependent from ACTH independent, because what the source of the Cushing is going to determine what kind of doctor is going to help you evaluate and manage the patient. So especially in women, ACTH dependent cases are much more common. And the vast majority of women, 161 out of 222, more than 3/4 of women have a pituitary adenoma causing their Cushing syndrome, and much less so, only 50% or so, is true in men. So in addition to pituitary adenomas, we have people making ACTH ectopically, both from benign conditions like carcinoid syndrome, sort of benign in quotes, and of course malignant cancers like small cell carcinoma. Many times we can't figure it out. And when it's adrenal, like in the case that I presented, it's equally possible that it's a benign or a malignant lesion. And there are a whole bunch of very unusual forms of Cushing syndrome where they have an aberrant receptor, which is activated by GIP or VIP or by LH, which for some reason those receptors activate cyclic AMP production in the adrenal tissue to make more cortisol. So why that happens is very difficult to understand, but it's rare. So basically, to summarize then, think about dexamethasone suppression test when you have these common findings in your patients. Screen them, I think, first with the overnight dexamethasone suppression test. If they pass, it's probably not Cushing's. If it's equivocal, or if they pass the dexamethasone suppression test, but you have a great index of suspicion that it really is Cushing's, then do a urinary free cortisol. Once you're convinced that the patient has hypercortisolemia, then you measure plasma ACTH, because you want to know whether a lot of ACTH is causing this or whether it's ACTH independent. So this is not helpful until you know this. Okay. And then if it's low, then you're generally dealing with adrenal problems. And if it's high, you're generally dealing with the pituitary problems. So here, of course, you'd go to a scan of the adrenals. And here you would go to an MRI of the pituitary. And that's probably where I would stop if I was a primary care doctor. The next case, a 43-year-old man is evaluated for high blood pressure. At the age of 29, he was found to have high blood pressure. during a routine exam, and he was initially treated with a beta-adrenergic blocker. Since that time, his blood pressure has remained high despite losing weight, compliance with his medications, and not drinking any alcohol. And his present therapy consists of hydrochlorothiazide, atenolol, and amlodipine. And on physical exam, he's not overweight now. He's still got high blood pressure. He doesn't have striae, abnormal facies, or achial enlargement. You don't hear any bruits when you listen to his abdomen or flanks. And his blood sugar's okay, but he's got hypokalemia. And his creatinine is 1.3 milligrams per deciliter. Which of the following would next be most appropriate in this patient? Okay, CT scan of the adrenals, 24-hour urine for aldosterone, fractionated metanephrines, aldosterone and renin, and MRI of the adrenal artery. Okay. Yeah, I agree with you that this is a time to think about primary aldosteronism. And primary aldosteronism patients have moderate to severe high blood pressure. It's frequently refractory to hypertensive agents. Severe hypokalemia can occur when diuretic therapy, perhaps because of the effect of aldosterone directly on signaling in various target tissues. They have left ventricular enlargement, renal damage, retinal problems, they get strokes, which are all seemingly out of proportion to their high blood pressure. The hypokalemia can also cause them to have neuromuscular symptoms, weakness, paralysis, cramps, fatigue, paresthesia. So all of those things occur with hypokalemia. They often have polyuria. That's another thing you get, the renal concentrating defect from hypokalemia. Even though they're making too much aldosterone, they're rarely edematous. The hypokalemia and other factors are thought to predispose to glucose intolerance, and occasionally you'll find someone whose serum sodium is high as well as the potassium is low. So who do you screen? So it's now thought that primary aldo is relatively common, and I'll show you that next. So therefore, we want to be increasing our net for the screening evaluation. And anyone who's got a very, very low potassium, less than 3, should be screened. Even though you think it might be due to diuretics, the vast majority of people taking diuretics like thiazides do not get this kind of profound hypokalemia. People who have very resistant hypertension, where you can't control it. Patients who have family members with hypertension who are young. And of course, all the people in whom you find a small adrenal adenoma, incidentally, when you do a CT scan for other reasons. So all of these are recommended to be screened. So in the past, we used to think as aldosterone, hyperaldosteronism is Cushing syndrome. That is an adrenal adenoma with hypokalemia. But nowadays, with advanced research in this field and the measurement of aldosterone and renin, it's clear that the majority of patients who have primary aldosteronism don't have an identifiable radiographic tumor. And these are 2 different studies, and they were done based on the finding of aldo-renin ratio and hypokalemia hypertension. So you can see that in each of these different centers, the number of people who have hypokalemia and hypertension, sorry, I'm in the wrong place, here it is. Let me get this right. Here it is. The number of people who have hypokalemia and hypertension and have an adrenal adenoma is really relatively small. The number of people who are diagnosed because they have the increased aldosterone to renin ratio is much higher in all of these centers. And if you look at the frequency of the aldosterone producing adenomas in each of these sites, the people who have hypokalemia and renin as a diagnostic criteria have much fewer adenomas than do the people who are diagnosed by hypokalemia and hypertension. So this is a much more, a much less stringent criteria, and if you have these criteria, you're more likely to have an adrenal adenoma. But nowadays, the aldosterone-renin ratio picks up many more cases than does the combination of hypokalemia. So, how do you collect the samples? Well, they suggest that you collect them in a seated position, and generally you're looking for an aldosterone to exceed the renin at a ratio of 20, or some say 30 to 1. So it's variable. You also want to have a substantial amount of aldosterone in the peripheral blood, and the general consensus is somewhere around 15 nanograms per deciliter. So we saw a case a couple of days ago. The person had 16. That was their diagnosis, and they had a small adenoma, and the nephrologists were sending him to surgery. The surgeons were a little suspicious, so Dr. Krishnasamy got involved in this case at the VA. One of the things about the aldosterone plasma-renin ratio is that it's influenced by a variety of drugs. So you need to, for sure, discontinue spironolactone when you do this evaluation, since spironolactone is going to increase the renin because it's blocking the aldosterone, so you get a negative feedback increase. You also have low renins with beta blockers, and you have an increase of renin with diuretics, ACE inhibitors, and ARBs. So all of those drugs really influence the renin and aldosterone secretion, and the best thing to do if you want to get it right is to just stop all these things, treat your patient with an alpha blocker and a calcium channel blocker for a while, and then do the assessment. You'll always want to make sure that you've replaced the potassium as well, because people who have hypokalemia, that inhibits aldosterone secretion and increases renin secretion, so that you will have a false negatives, if you will, for the aldosterone if you have hypokalemia. So watch the drugs and replace the potassium. After you have a high aldosterone and a low renin, that doesn't make the diagnosis, because there's such a thing out there as low renin hypertension. I still don't think people understand what it is, but what it is an increased sensitivity to the renin that you're already producing, or some other mechanism which is stimulating aldosterone, which is renin independent and is not yet understood. So you cannot simply use the aldosterone renin ratio, but the next step is to show that the aldosterone cannot be suppressed. And you can the most typical way is to just give a couple of liters of saline and measure the aldosterone before and after. So 2 liters of saline over 4 hours is the most typical way. And in general, people who have hyperaldosterone have high values, much higher than this. The values of 10 or so are a little bit equivocal. Hopefully you won't be in the equivocal range. But if you have a very high value both before and after with minimal suppression, and I'll show you some data in a minute, that's more likely to be primary aldo. Other people give oral saline, and some have given Flurinef for a few days as other alternatives to increasing the volume and proving that you can suppress the potassium. So this was Dr. Weinberger some years ago now, and these are the people who are normal, and you can see that all of his normals fell to less than 10, and here's where they got the 5 from. The median was 5 after the saline infusion. Here are the normals beforehand. You can see that many people who had primary aldo have aldosterone concentrations which are not any different than normal individuals, but after you gave the people the saline infusion, the ones who were proven to have primary aldo had much higher levels, and most, so you can see the average here is about 25 or 30 after the saline infusion. There are a couple of patients, occasional, who are close to normal, and of course that's what causes you to have a lot of havoc. So when you have primary aldosteronism with high aldosterone and low renin and failure to suppress with saline, what could be the mechanism? Well, I already alluded to the fact that in the past it was primarily an aldosterone-producing tumor, but nowadays no tumor is identified in the majority of the cases, and they have a bilateral disease called bilateral adrenal hyperplasia, which so far doesn't have a pathogenesis. Occasionally you can get it with unusual things, cancer of the adrenals, There's familial syndromes. There's something called glucocorticoid remedial hyperaldosteronism, which is a gene mutation, and various forms of congenital adrenal hyperplasia can also produce this problem. So this is the CT scan. So here you can see an adrenal adenoma here, and you want to look at both adrenals. If you have a nice big old adrenal on one side and the other adrenal looks fine, it's generally a aldosteronoma. But in many cases, you have abnormality on one side and the other side is sort of equivocal. And something that we'll often have to do then is selective venous sampling, where our radiology colleagues will slide a catheter up here into the adrenal veins, which is relatively simple for them on the left side, but very, very difficult on the right side. You can see getting a catheter which does that, makes like a 135-degree angle, takes a lot of skill and experience. And sadly, sometimes we don't have a positive result. But the idea is, just like in any endocrine disease, the closer you get to the source of the problem, the higher the hormone concentration is going to be. Just like the light law, inverse square to the heat of being closer to a bulb. So if you get a sample of aldosterone coming out of this adrenal, and it's 20 times higher than this adrenal, it's pretty clear that that's where the problem is. Well, there are a lot of tricks and details of doing that, but that's the basic idea of selective venous sampling, simultaneously assessing what's coming out of the right and left adrenal, and using that information together with your radiographic findings. So, this is probably now the most common form, bilateral adrenal hyperplasia, identified with plasma aldo and renin, confirmed with the saline. They generally have milder abnormalities than the adenoma. The CT scan could be normal. It can show bilateral disease enlargement or nodules. If you're thinking of surgery, you want to do adrenal vein sampling, but in general, these patients can be treated medically and the outcomes are just as good as the surgical outcomes. Next case. A 40-year-old woman presents with a 2.3 centimeter left adrenal mass. She was seen in the emergency room 1 week ago with right up quadrant abdominal pain. The CT scan reviewed only an adrenal mass. The review of systems, vital signs, and physical exam were normal. The family history was unrevealing. What's the next step in how you manage the patient? Reassure the patient and suggest she have a follow-up CT in 6 months. Arrange for a CT-guided needle biopsy. Refer her to a surgeon. Order an MRI of the adrenal. And evaluate for Cushing's and primary aldo. Okay. Well, that's what I would do. I would evaluate her for Cushing's and primary aldo at that time. That would be my approach. So if you find an adrenal adenoma on a scan, on a CT incidentally, there are a wide variety of differential diagnoses, and the vast majority of the tumors have the radiographic characteristics of an adrenal adenoma, more than half. And of those half, the majority are non-functional benign adenomas. About 25% of these adenomas, so about 10% of all adrenal adenomas, are really cortisol-producing adenomas, and some people call this subclinical Cushing syndrome, like they call it subclinical hyperthyroidism. But very often when you talk to these patients, if you're careful in taking a history, they'll have some things which go along with Cushing syndrome. So call it subclinical if you want, but it's Cushing syndrome. And much less often, but still 6% out of the 50, so 3% of all the cases have aldosterone-producing adenomas. Sometimes you have an adrenal cancer or a pheochromocytoma. Sometimes it's a myelolipoma, and then some other unusual diagnoses as well. So one of the things about distinguishing the adenomas from these bad things is the size. And when you find small tumors, like in our case, the vast majority of the small tumors are benign. The vast majority of these bad things, including pheochromocytoma, when at the time of diagnosis are big. It doesn't mean that these big things don't come from small ones, but at the time of diagnosis, the vast majority of these are enlarged. And it also doesn't mean that enlarged tumors can't be benign, since they can, even much, much bigger than this in other series. So what do you do here? Take a careful history and physical exam, do the things that were recommended in that case, dex suppression, and measure PRA and aldo if hypertensive. My own evaluation often includes women with hirsutism, so when I think about these things more often than some, so I'll measure DHA sulfate and testosterone when there's some clinical suspicion of increased androgen production, and also we'll measure the 24-hour urine metanephrines. And if they're abnormal, any of these, then you confirm them, and the vast majority of these patients will be surgical candidates. If these values are all normal, then you look at the CT scan with the radiologist, and you look to see whether he thinks that the characteristics of the CT are benign or worrisome. And among those things are what they call a rapid washout, the disappearance of the contrast from the lesion over time, and the intensity of the contrast, which they call lipid-rich with Hounsfield units. So if it looks like it's lipid-rich and it has rapid washout, they will tell you the majority of those are benign. And if that's not the case, then many of those are malignant. When they're benign, then you just follow them. And if there's tumor growth, then you probably wind up taking it out. And if they look bad, you can either operate, which most people probably do. Occasionally, patients will have a fine needle aspiration of the lesion, and in some cases we'll choose not to operate, but just to watch, depending on the type of patient and what the morbidities might be. Okay, a 53-year-old man undergoes preoperative treatment before a removal of a pheochromocytoma of the right adrenal gland. The PET scan shows no other focus of his tumor. Which of the following is the appropriate preoperative management for this patient? A, administer saline and an alpha blocker. Yeah. Treat with a beta agonist, antagonist, sorry. Administer alpha-methyl dopa to delete the patient's catechol stores. No. Order a MIBG scan. No. That's right. I agree. So, people who have pheochromocytoma often have sustained or paroxysmal high blood pressure. Sometimes they have normal blood pressure. And very often, because of the catecholamine production, they have orthostatic hypotension. So that's a little bit of a pearl. And they have this constellation of clinical findings: headache, sweating, and pallor. The catecholamines cause a type of cardiomyopathy. And some patients with pheochromocytoma will present like CHF patients. They may have arrhythmias. And because of the catecholamines, they often have panic attacks and nervous attacks, which can last a few seconds to many hours. And this is the cause of many of the patients being referred to you and then to us for an evaluation. So you remember your catecholamines, norepinephrine and epinephrine, which are metabolized by catecholaminar-O-methyltransferase to normetanephrines or metanephrines, and then oxidized by monoamine acid oxidase here, MAO, and to something called VMA. And in the past, the VMA was the standard urinary screening test, but nowadays normetanephrines and metanephrines, either in the urine or serum, those assays have been refined by LCMS, liquid chromatography, mass spectroscopy, and these are the usual things which are done to evaluate patients for possible pheo. And there are advocates of urine, there are advocates of plasma. You read this in the literature. You know, people are very vehement about one or the other. So these are just some data. So here you can see the people with pheo. This is their urine, this is their metanephrines, this is their normetanephrines, and you can see that the vast majority of people with pheo have higher normetanephrines and higher metanephrines in their urine and in their plasma than do the controls, although there's a little bit of overlap in every circumstance. So none of them are perfect. But that's where you start. Now, how do you get in trouble with evaluations for pheo? The first thing is to remember that the pheos sometimes produce catecholamines episodically for reasons that are not clear. So if you're very concerned and convinced that this is what the patient may have, and the first set of tests are normal, do another set, especially at a time when they might be having a spell. So if they're having something the matter with them, you tell them to come on in, go to your lab, and have their catechols measured. Much more often, though, are false positives. So people who are under stress of any sort can have high catecholamines. Even the stress of drawing the blood sample. So a common approach is to put an IV in their arm, bring them in, have them in a dark room, lie down, and after 20 minutes or so, draw the sample. And perhaps the biggest problem is that so many different drugs interact and have overlap with the assays for metanephrines and norepinephrines, including this whole list of drugs. So when you want to evaluate your patient for pheochromocytoma, look at the drug list, try to exclude temporarily the drugs which might interfere with testing. Phenothiazines, amphetamines, these are all just source of constant, unnecessary expensive diagnostic tests, because the doctor doesn't realize that the drugs that they're taking are really the source of the abnormal test. So you have this area then. If you look at any of them, plasma, metanephrines, or urine, if the values are normal, they're probably normal. If they're more than twofold above the normal range, there's a good chance that the patient has a few. But all of these people are in that gray area, and that's where you want to get numerous tests, and you want to be sure what you're dealing with, exclude the drugs as possible effects. So, of the pheochromocytomas, the majority of them are in the adrenal medulla, but they can be outside the adrenal. They can be in sympathetic nerves in the pelvis, something called the organ of Zuckerkandl. They can be in the neck. They can be a wide variety of places. The majority are benign tumors, but some are not. Some are malignant. The majority are sporadic, but some are not. And among the things you might be asked on the boards, I know everyone wants to know about the boards, so what kind of gene defects are associated? Now, they might show you a obvious pheochromocytoma picture, big adrenal hemorrhagic tumor, what's the diagnosis? So, or they might show you a picture of someone with neurofibromatosis. Pheochromocytoma is rare in neurofibromatosis, but it's much more common in MEN2, and the abnormality there is an oncogene called RET, which is mutated in MEN2. Von Hippel-Lindau disease, the VHL gene is mutated. That's a disease where you get vascular malformations in the brain and eye. So if you look in the person's eye and see all this vascular malformation, and the patient's hypertensive, that's how those are connected. And this one is a little trickier. It's a succinate dehydrogenase is part of the intracellular transport in mitochondria, and these people get extra adrenal tumors, and they get hypertension, but they sometimes have sort of vague symptoms of fever, palpitations, and very unusual type of symptomatology. So PET scan seems to be quite good in identifying metabolically active tumors, such as neuroendocrine tumors, which includes pheochromocytoma. So this is one PET scan here, and I guess these are all PET scans. And you can just see how the scan really shows very, very hot lesions in patients with it. I thought I had one which had a MIBG in comparison to that, but I didn't plot that. But here you can see how you can get these very, very hot lesions. So once you're sure that the patient has a pheochromocytoma, then you want to do the PET scan, because you don't want to take the patient to surgery for an adrenal tumor when they have this. You're not going to cure them by taking out their adrenal. So this has become part, I think, of the diagnostic approach, but downstream really of making the diagnosis is helping the surgeon to define what kind of surgery, if any, needs to be done. So a 36-year-old woman has diabetes type 1 since age 14. Starting 6 years ago, her skin became lighter in blotches, and more recently she has experienced increasing frequent episodes of hypoglycemia. Her weight has declined 10 pounds. She feels weak and dizzy. and her skin pigmentation seems to be increasing. And she was admitted to the blood glucose of 32 milligrams percent. And which of the following tests would be useful in establishing the cause of her hypoglycemia? Urinary free cortisol? Cortisol stimulation test? Dexamethasone suppression test? CT of the adrenals? And the cortisol in morning and evening. Well, that one we didn't have such good unanimity, so we'll just talk about it. So my diagnosis is that, and of course I'm thinking that the diagnosis might be, could this patient have Addison's disease, an autoimmune disease, in the setting of another autoimmune disease, type 1 diabetes? So free cortisol, especially at a time when you're hypoglycemic and under stress, the levels of excretion are probably going to overlap the normal range, so it's not going to help too much. The dexamethasone suppression test is for Cushing syndrome, not in a differential at all. Occasionally you'll find some information on a CT scan which bears on the pathogenesis of the adrenal failure, but you haven't figured out the patient had adrenal failure yet, so certainly adrenal CT from a financial point of view would not be the logical thing to do at this time. And plasma cortisol levels admittedly have a diurnal rhythm in normal individuals, but in a given person the failure to find the diurnal rhythm in a hospitalized setting doesn't really have a lot of clinical significance. So I was thinking that maybe this patient has Addison's disease, hyperpigmentation, vitiligo, weight loss, weak and dizzy. All of those things are common things, admittedly, especially in people with diabetes. But on the other hand, you got to be thinking out of the box. And Addison's disease, as Kristen said, is one way to put it together. So when you have adrenal failure, it can be primary, something's the matter with your adrenals, or secondary, the adrenals are not being told what to do. People who have primary make more ACTH and MSH. Both of those are pigmentary hormones, so a lot of patients will tell you they're hyperpigmented. If you have something the matter with your pituitary, often you have other types of hypopituitarism. Ask a woman about her menstrual periods, for example. And fatigue and weakness certainly can occur in both of them. When you have primary, it often goes along with other autoimmune diseases, the vitiligo, the type 1 diabetes, the thyroid disease, celiac disease. On the other hand, people who have pituitary problems think about headaches. And of course, when you have primary adrenal disease, not only is the reticularis involved with cortisol production, but most often the glomerulosa is involved, so you have aldo deficiency and hyperkalemia, and that doesn't happen in secondary. There's nothing wrong with the renin-angiotensin system in hypopituitarism. It works fine. So you don't get hyperkalemic. Of course, people who have pituitary tumor can have a visual defect. And because of the aldo deficiency, this group of people have dehydration. And of course, this group of people may have a history of steroid abuse, injections from their pain doctor. I saw a guy last week and taking large amounts of methylprednisolone. His primary care doctor didn't realize that was a steroid, and that's why he had a low cortisol. And remember that many things look the same. Both the symptoms and signs are quite comparable in both primary and secondary. Fatigue and weakness, anorexia and weight loss, nausea and vomiting, hypoglycemia, as in our case, and hyponatremia. So there are many symptoms and signs which are shared by primary and secondary, but if you're a student, you don't even have to do any laboratory tests. You can see all of these various clinical findings distinguish one from the other. So when you have primary, I mentioned before, not only is your cortisol decreased, but your aldo's decreased, and that predisposes to dehydration and hyperkalemia. Whereas people who have secondary adrenal insufficiency, the cortisol is decreased because the ACTH is decreased and their aldosterone is fine. These people get hyponatremia because cortisol is necessary in the movement of the aquaporin channel in the kidney from its intracellular to its membrane location. And that's why cortisol deficiency simulates SIADH. So you get an accelerated transport of the phase of aquaporin to the membrane in the proximal collecting duct, and therefore you get more water absorption in cortisol deficiency. And of course in SIADH you get more of that protein produced as well, so that the two share the end mechanism really. And therefore when you're thinking of someone has SIADH, you always got to know what the cortisol is, because if you don't, everyone with cortisol deficiency, which is secondary, is going to be thought to have a SIADH, and you'll miss everyone who has cortisol deficiency if you don't look for it. So these are just some data. Here are the ACTH levels and the cortisol levels in some people with Addison's disease, and you can see that they have a very high ACTH. So diagnosing Addison's disease with the ACTH assay is a good way, just like diagnosing hypothyroidism with the TSH assay. The only difference is that our hospital labs tend to run the TSH once or more every day, and they tend to send out the ACTH level because we rarely order it, and it may take you a week to get it back under certain circumstances. You can see that the cortisol level, here's 10 micrograms per deciliter. The values here are plotted in nanomolar. So here's 10. You can see that many patients who have Addison's disease have cortisol levels which are close to the normal range, just like many patients with hypothyroidism have free T4 levels which are close to the normal range. So here are the normal controls: much higher cortisol levels, much lower ACTH levels, but yet some overlap in the cortisol. And here are the aldosterone. So the aldosterone levels are much lower in Addison's disease, and the plasma renin activity is much, much higher. It's responding to the volume contraction. So we often do the ACTH stimulation or cortisol test in the hospital. Perhaps you understand it, but sometimes I find that there's a lot of confusion about it. So a normal individual has a plasma cortisol in the morning of somewhere between 12 or so and 25 micrograms per deciliter. Here the average was about 17. And you can see when you give cortisol, the level of cortisol rises between 1 and 2 hours, so that's when we usually measure the blood. And many people have found that the peak levels exceed either 18 or 20, or there's an increase of 8 micrograms percent from the baseline to the peak. So you have to get the baseline and then 1 hour and 2 hour. You can't get the baseline today and inject it tomorrow morning and then get the value 2 hours later. It's a mess. You want to do it in an organized and structured way. So when you have Addison's disease, you're already making lots of ACTH, and therefore if you inject some ACTH, and this is basically a form of ACTH, not a whole lot happens because you're already making a lot of ACTH. So the increase after the cortisol is minimal. Okay. That's different than the people who have pituitary problems. So the ACTH upregulates many of the steroidogenic enzymes. So in the absence of normal ACTH production, those enzymes are less. They're produced less. And therefore, when you inject ACTH into them, there's less enzyme to make less cortisol. So people who have hypopituitarism do increase after ACTH, but they don't increase normally. So when you find an attenuated response, although a response, that goes along with secondary. That's why it's so important to get the values all at the same time, not today and tomorrow, this morning, this afternoon. You know, you can't put it together. But these are the people who are the biggest problem. The second biggest problem is our failure to remember that most cortisol in the blood, as much as 80%, is bound to albumin. There isn't any sex hormone binding globulin or thyroid binding globulin, which are high affinity binding proteins for cortisol. Why that is, I don't know. But if your albumin is low, you have a low cortisol. So our hepatologists have a hepatoadrenal syndrome. They think that the people have adrenal insufficiency. because they have lower cortisol levels and they have an attenuated response to corticotropin in the setting of liver disease. Well, all of us know that when you have a sick liver, you don't make too much albumin. So these are the results in healthy subjects who've had a corticotropin stimulation test. Here's the baseline. Here's the stimulated. And these are people who are sick, and they are broken down into those who have a low albumin and those who have a high albumin. So you can see that there's a much, much attenuated cortisol response to ACTH in the people who are hypoalbuminemic than there is in the people who are sick and have normal serum albumin. And you can see that many of these patients would fail by the classic criteria of an increase of 8 or a value of 18 or 21. So those criteria for what a normal response is don't apply when you have a normal albumin. And here's a circumstance where you might want to collect a 24-hour urine sample, because there you're going to have an integrated secretion of cortisol. And if you're not compelled to treat the patient abruptly because they're extremely hypotensive, once you put people on steroids, you often have a mess. So the thing to do is to get it right to begin with. Sadly, we don't really have free cortisol assays for plasma, so that we really don't have the same armamentarium that we have for some of our other measures. So when you have primary adrenal insufficiency, way back when, the most common diagnosis was TB. But nowadays, in women especially, the diagnosis is more often autoimmune. And in men, there's a diagnosis called adrenomyeloneuropathy, a disorder of peroxisome metabolism, Lorenzo's oil, if anyone happens to remember that. And things such as metastatic cancer or hemorrhage, of course, can damage the adrenals in both sexes. Rarely there are mutations of genes responsible for cortisol production, which cause adrenal failure. I just want to mention bilateral adrenal hemorrhage is something we don't want to miss. I missed it when I was an intern and resident, sadly. Of course, it was a couple of years ago, and it was a little less well known, so I don't feel so bad. But I don't want you to miss it. So it's this situation where people get hypotensive, and that's a very common presentation, unexplained hypotension in an intensive care unit setting. From the hemorrhage, they may have back pain and fever because of bleeding into the retroperitoneal space. Another thing is an abrupt change in the hematocrit. They can get abdominal pain as well. They can get electrolyte disturbances, but not always, because in our intensive care unit, we're constantly monitoring the sodium and potassium and adjusting our electrolyte infusion, so that some people get missed. And one of the factors which predisposes to it is anticoagulation. So it's a cause of abrupt bilateral adrenal hemorrhage. I thought I had a picture, but I didn't. So when you think someone has acute adrenal insufficiency, you want to do the diagnostic tests if you can. Certainly measure the ACTH and the cortisol, and if time permits, do a corticotropin stimulation test. Of course, as the patient is dying and you think they're dying from cortisol deficiency, you want to give them therapy immediately. We usually use hydrocortisone, although it doesn't really matter, and we usually give 100 milligrams 3 or 4 times a day. Of course, if their volume contracted, you concomitantly treat them with dextrose for hypoglycemia and saline, and of course figure out what's the matter with them. So this is the last slide. A 35-year-old woman seeks your advice about ongoing glucocorticoid therapy. She has taken prednisone intermittently over the past year in doses of 15 to 20 milligrams, and her rheumatologist has advised her to reduce this medication since it's causing her to have muscle weakness and osteopenia. And on physical exam, she is overweight and hypertensive, and she has the features of Cushing Syndrome with facial plethora, central fat distribution, bruises, and proximal muscle weakness. So which of the following approaches would you select to do? Discontinue the prednisone. Gradually decrease the dose of prednisone over 3 to 6 months. Or perform an ACTH stimulation test. Perform an insulin tolerance test. And measure the level of ACTH. Not a lot of opinion here. Okay. So that's what I would do. Just slowly reduce the dose. And the reason for that, first of all, you can't discontinue the prednisone. Someone who's been on therapy for a long period of time will have suppression of ACTH production, and it takes quite a long time to recover after the steroids have been administered in high doses for a long time. So they will crash. And if you do that in the hospital setting, we see all the time, our interns and residents, someone comes in with pneumonia or something else, they don't like the idea that they're taking steroids, maybe the steroids is limiting their ability to fight infection, or this, that, and the next thing, and they think the smartest thing to do is to stop the steroids. Well, it may be true that the steroids are limiting the infection, but when you stop the steroids in someone who's been taking high-dose steroids, you have someone who becomes adrenally insufficient, and you have a big problem on your hands some 24 to 48 hours later. So don't do that. If the patient looks Cushingoid, and you can tell on the physical exam, they're going to have a suppression of ACTH, and those enzymes then are going to be downregulated. So although you can do this, pretty much worthless. It's not really going to make any difference in how you manage the patient. It's just spending a lot of extra time and money. So I don't do that. Insulin tolerance test is a way to look centrally at the production of ACTH, but the same is the case. That is, someone who looks like they're Cushingoid is certainly going to have an impairment in insulin-provoked hypoglycemia. So it's quite, although it's very simple, it doesn't involve any evaluation at all. And I just did it last week. The guy comes in, his doctor's referring him. He's done this test. The guy has a cortisol of 1.4, and he stimulates to 12. Does he have hypopituitarism? Meantime, he's taking all this methylprednisolone. So all you have to do is really just stop it, because so many other tests are abnormally affected by the high-dose steroids. The testosterone goes down, the TSH goes down, the growth hormone goes down, everything goes down. You will think the patient has hypopituitarism, and you really can't figure it out at all as long as they're on high-dose steroids. So the only thing to do is to gradually reduce the steroid dose. Right. So then just finally, when you as I was alluding to before, when you have someone who's taken steroids for a while and they come in sick in the hospital, you don't want to stop the steroids. Instead, what you want to do is give them extra steroids. Even if they're taking 5 or 7.5 milligrams a day, you want to double that during the time they come in with their MI or pneumonia, because a normal person would make a lot of cortisol. Your UFC and your cortisol production rises with stress. That's a stress response. So if you have someone who's on maintenance steroids and they come in sick, you want to give them a little more, not a little less. And it's logical replacement in an intensive care unit setting. And like I mentioned before, some 150 or 300 milligrams over 24 hours of hydrocortisone is a typical response. Okay, so I open this up for questions and comments from the VA too. Nice to hear you folks. Yes, ma'am.
Regarding secondary renal insufficiency, I had a patient a couple of months back. He was transferred from the NICU, and he was documented to have a non-sick brain injury. He stayed in the hospital for around 2 months, and towards the end of his discharge, he started getting hypotensive, orthostatic hypertension, and so we were considering adrenal insufficiency.
So the question is, how often, if someone's very sick and they've been in an intensive care unit and they have taken steroids or they have not?
They haven't been on steroids.
They have not received steroids. And then they're still sick at the end of the hospitalization and they have orthostatic hypotension. And how often is that due to ACTH deficiency? Very rarely. Orthostatic hypotension is a very common problem, and it's especially common when you've been hospitalized and sick for a long period of time. So I would not quickly jump to the diagnosis of ACTH deficiency until you document it biochemically.
Cortisol levels were low, morning cortisol levels.
Well, it's to have low albumin. This is what I say, that the low albumin in the setting, so the cortisol levels were low. So that's what I'm saying, is that the cortisol levels in the setting of low albumin can't be interpreted in the same way as cortisol levels with high albumin. Could your patient have ACTH deficiency? Sure. Is it a common scenario? No. And would I quickly send him out on steroids without figuring out really what's wrong? No.
Thank you.
Yeah. Other questions, comments? Okay, thanks for your attention.